I'm Michael Cecchini. I'm moderating this session tonight. I'm one of the GI medical oncologists here at Yale. I focus on colorectal cancer as well as other gastrointestinal cancers. I co-direct the colorectal cancer program. Joining me tonight in presenting is Dr. Sidney Bogardus from gastroenterology, Dr. Kevin Du from radiation oncology, Dr. Ann Mongiu from colorectal surgery, and Dr. Jeremy Kortmansky from medical oncology. Throughout the evening, if you can put your questions into the chat in the Q&A session, and we'll collate the questions and ask them at the end of each individual presenter's talk. And without further ado, I'd like to introduce our first speaker tonight from gastroenterology, Dr. Sidney Bogardus.
Well, very happy to be here this evening. Colon cancer is a topic near and dear to my heart, and this is Colorectal Cancer Awareness Month, so a good time to be talking about it. So you'll hear lots about treatment of colon cancer in all its various forms from the other speakers tonight, but I'm going to focus on what we do to try to prevent it in the first place, and how to keep you from seeing these other folks. So I'm going to talk about screening. But I'll talk first a little bit about just some background about colon cancer in general. So next slide. Colon cancer and rectal cancer are very common. We usually lump them together as colorectal cancer. And overall, it's a common condition. So colorectal cancer is the third most common non-skin cancer in the US, and the second most common cause of cancer death in the US. A lot of cases, a lot of people have it. There are approximately 150,000 new cases each year in the US, and about 50,000 deaths each year in the US. And if you try to look at your lifetime chance of getting colorectal cancer, it's about 4%, 5% in that range. So it's an important thing to think about. Next slide. Things have happened to the trends of colorectal cancer incidence over the years, and some of it's pretty good news. So if you look over the last 40 years or so, 40 to 50 years, there's been a gradual decline in incidence and mortality of colorectal cancer, which is great news. And some of that's due to changes in some of the risk factors that we'll talk about, also probably due to early detection and polyp removal and advances in surgery and treatment. There's been a slight little wobble in those numbers over the last 5 to 10 years, which is something to keep an eye on. And there's also a little bit of not so good news, which you may have seen in the press, and which is worth mentioning, which is that it appears that there's an increasing incidence of colorectal cancer in people under the age of 50, in that 20 to 49 year range. It's still not common, so I don't want to over scare people, but it's worth noting this gradual uptick in that age range. Probably about 10% of colorectal cancers occur in this age group. So next slide. How does colorectal cancer start? Well, this is where we get lucky with this condition. Most colorectal cancer, probably about 95% or so, starts as a polyp. And a polyp is just a little bump of tissue that grows in ways it shouldn't. Usually has some genetic abnormalities in it, and it sits there. So polyps are incredibly common, by the way. So at least 1 in 3 people over the age of 45 to 50 have polyps. If you look at some studies, even more people than that have it. So polyps are incredibly common. And when I do a colonoscopy and find polyps and people say, is that normal? My answer is, yeah, it's so common, it's almost normal to find polyps. Polyps are really lazy usually, and they're pretty slow growing. So it takes about 10 years or more most of the time for a polyp to turn into cancer. And that's a good thing for me, taking care of you, because that gives me the opportunity to go in there and look for polyps and take them out before they turn into cancer. So that gives me the opportunity to potentially prevent cancer before it starts. Next slide. Just a quick word about types of polyps. And I only mention this not so that you need to memorize this, but simply because you'll see these on the reports if you do get a screening colonoscopy. There are multiple types of polyps, and I'm going to mention 3 here. There are other ones that I don't think are worth talking about tonight, but the most common type of so-called precancerous polyp is an adenomatous polyp, and that probably accounts for about 70% of colon cancer. There are also something called sessile serrated polyps, and these account for probably about 1/4 maybe a little bit more of colorectal cancer. These are things that when I was starting out, we weren't so aware of, and we've become very aware of over the last 10 to 20 years. And then lastly, you'll see if you get a colonoscopy, you might see mention of something called a hyperplastic polyp. And that's another type of polyp that's benign and doesn't turn into cancer. So we don't worry about those as much. Next slide. What about risk factors for colorectal cancer? This is important to think about because some of them are modifiable. Age is not, and it turns out that colorectal cancer does get more common with increasing age. A personal history of either polyps or cancers is very important. And this is something that we look at when we see people in the office, because that can influence your chance of having further polyps or cancer and what we do about that. A family history is also incredibly important. So we're very interested in whether people's relatives have had colon cancer or polyps, especially first-degree relatives. First-degree relatives, if you have colon cancer or polyps in those folks, it confers more of a risk than more distant relatives like aunts and uncles and grandparents. There are some medical conditions that also enhance your risk. So things like ulcerative colitis and Crohn's disease can increase your risk of colorectal cancer. And a long list of other things. And these include things like obesity, tobacco use, excessive alcohol use, diets that are high in fat and low in fiber, processed meats, even intake of red meat has been associated with it. And lastly, inactivity has a pretty strong relationship with colorectal cancer. So obviously, these last list of risk factors are interesting because you can change many of them, and that's good news. So next slide. There are also some protective factors because, a lot of questions people have are what can I do to reduce my risk of getting colorectal cancer? Physical activity is consistently associated with risk reduction, maybe a quarter. Now, it's a little complicated because that's tied in with things like diet and healthy lifestyle, but it does seem to have an independent risk. Everybody wants to know about diet and how it can affect your risk of colon cancer. And there's a lot of tantalizing data about various things such as fruit and vegetable intake, fiber intake of certain supplements like folate or various vitamins or calcium or vitamin D, and even things like garlic and fish intake and coffee intake. And many studies for all of these have suggested a potentially beneficial role, probably not enough to recommend that you go out and consume a whole bulb of garlic every day, but just kind of strands. And a lot of this, as you can see, goes along with a healthy diet in the first place. And another protective factor is intake of things like aspirin and Advil and Aleve. This is also quite interesting. And these have been shown in multiple studies to reduce risk of polyp formation and transformation. So much so that the American College of Gastroenterology actually says that if you have another reason to take aspirin, protecting yourself from colon cancer is an additional reason, although probably not all by itself. So something to keep in mind. So next slide. So screening, when we talk about screening, we're usually talking about detecting cancers early. Colon cancer is a little bit different. It's definitely important to find colorectal cancer early, because if you find it early, it's very easy to treat. So early localized colon cancer is associated with a very high survival rate, more than 90%. But the actual fact is that polyps are far more common than cancer. So when I do a colonoscopy, I'm usually looking for polyps, not cancer. Again, to go back to the fact that I told you before, at least 1 in 3 people will have polyps. And by removing polyps, I can prevent that cancer. So a colorectal cancer screening program is unusual in the fact that prevention is as important as detection. And I think that's important to keep in mind when you think about colorectal cancer screening. It's not so much the cancer screening, it's cancer screening and prevention. So next slide. And screening works, and this is a key point too. So multiple studies have shown that screening can reduce colorectal cancer incidence and mortality over years. And this is a consistent finding for various strategies to screen. Next slide. One quick caveat though. Screening means you're testing somebody who doesn't have any symptoms. If you have symptoms, the tests we do are no longer screening tests, they're diagnostic tests. So there are some concerning symptoms that we sometimes see, like rectal bleeding or abdominal pain, or a change in your bowel movements, or weight loss. Anything like that should prompt you to see your doctor, because we're no longer talking about doing a screening test. We're talking about doing tests to figure out why you have those symptoms. Next slide. So who should get screened? Well, this is one of the new bits of information. It used to be we screened everybody 50 and older, or asked people 50 and older to come in for screening. The new recommendation is to start at age 45. And that goes back to that early slide I showed you about the increase in incidence of colorectal cancer in people under the age of 50. So when people have modeled out what the appropriate thing to do is, the new recommendations are to start at age 45. That first came out with the American Cancer Society in 2018. And then a couple of other societies, including the US Preventive Services Task Force, added that as a recommendation in 2021. When the American Cancer Society came out with that in 2018, many of the insurance companies hadn't caught up with that. Essentially now, virtually everybody has. But there are some people where the 45 rule doesn't apply. So you see some asterisks after the word older at the top, and I'll talk about that in a second. There are also some people where you should think about screening when you're younger than 45. So people who have a family history of colon cancer or advanced polyps or certain genetic conditions should potentially get screened when they're younger than 45. That's something that you usually talk about with your doc. Also, if you have a personal history of certain conditions, such as longstanding ulcerative colitis, you may be an appropriate candidate for screening when you're younger. Next slide. How about the question about when I can stop getting screened? This is one of the most common questions I get. You know, okay, doc, I'm 76, I'm done now, right? Well, it's a great question. And it's not quite so simple. Virtually every organization recommends that you should continue getting screened until you're 75, unless your other health conditions prevent it. And there are some people where it may not be appropriate to do that. The age of 70, between 75 and 85, is a complicated one. And it's very hard to do clinical studies in this. People have done a lot of thinking and a lot of modeling. And again, most of the organizations have come to the conclusion that in this age range, continuing screening should be an individualized decision depending on your overall health and your personal preferences. If you haven't had any screening before, some studies would suggest a benefit from continuing into your 80s. Again, it's a complicated topic. It's one that you have to wrestle with. It's one of the most common discussions I have with folks in this age range. Do I continue or do I stop? But definitely worth discussing. So next slide. How are we doing with screening? Yeah, we're doing so-so. The goal from the National Colorectal Cancer Roundtable is that we get 80% of people screened. Most of the data right now suggests that we're screening about 60% of people overall. In that new age range of 45 to 50, we're well under 20%. Part of that's probably because it's a new recommendation, but there's a lot of room for movement with that younger age group. Next slide. So what's the best screening test? The answer to this is in some ways really simple. The test you get is the best test. I mean, I'd rather see somebody get any test than no test. Anything we can do to budge the needle on the number of people getting screened is a good thing in my view. Next slide. You've got a bunch of options. There are one-stage tests like colonoscopy, which detect and remove polyps at the same visit. And there are what you might think of as two-stage tests, which is everything else. Those are tests where if you have a positive test, you then need a colonoscopy to look for and remove polyps. And these include some stool-based tests and some other tests. Next slide. How about colonoscopy? Well, it is really the gold standard. And I think everybody now knows what a colonoscopy is. It's a flexible tube with a camera that lets us look up into the colon. It takes about 30 minutes. You're asleep. You don't notice anything. You get a great nap. It has some pretty clear advantages. It's far and away the best test at finding both polyps and cancer. And it also lets you take out the polyps at the same visit. But it's also got some disadvantages. And, you'd be foolish not to acknowledge these. It needs a bowel preparation, everybody's favorite part of a colonoscopy. You got to take something to flush out the colon. The good news here is that there are lots of options, and there are some new options, including a pill-based option that seems to be a bestseller in my practice. It's also got cost and inconvenience attached to it. But if it's a screening colonoscopy, it's fully covered by insurance. There's also a little bit of risk, but complications are actually very rare. Next slide. The stool tests are the other sort of large group of tests that are worth talking about. And I'm going to mention three quickly here because these are important for various reasons. The first one is something called a fecal occult blood test, and it's an indirect test looking for the hemoglobin found in blood. It's an old test. We don't use it much anymore because there are better tests now, but I mention it because it was the test that was used in all the trials that showed that screening saved lives. So you'll still hear it mentioned. What sort of took over for it is something called a FIT test, or a fecal immunochemical test, which is a direct test for that hemoglobin in blood. It's a bit of a better test, and it seems to perform quite well, but it does need to be done every year. It's not as sensitive as colonoscopy for polyps or cancer. And probably the newest kid on the block, and the one that I think I get asked just about the most questions about, is the Cologuard test, also called a FIT DNA test. And this is a test that combines several things. It combines that FIT test above for hemoglobin, plus tests that look for certain types of abnormal or altered genetic material in the stool. It's really come on strong. It's being marketed heavily, and it's actually pretty widely used. At least 10 million people or more have had a Cologuard test in this country at this point. Not as sensitive for polyps, but it's almost as sensitive for cancer, actually. Next slide. So these stool tests have a lot of advantages too, and their advantages are pretty obvious. Cost is less, they're easier to use, they're more convenient because you can do it at home, and they don't have any risk. They have some disadvantages too, just as a colonoscopy does. They're less sensitive for polyps and cancer, so there are a lot of false negatives. They have to be done more frequently. So to make these programs work, you really have to do them every 1 to 3 years, depending on the test. They have a little bit of an ick factor. Some of my patients have complained about this. With the Cologuard, you have to give a complete stool sample, which can be unnerving for people. Cologuard is actually not cheap, which has affected some of the screening recommendations for it. Most of the time, it's more than $500, although it can be covered. False positives are an issue. So the false positive rate, meaning when the test is positive, but you don't have a polyp or cancer, it's about 13 to 14% with Cologuard. That actually translates, and I won't do all the math for you, but when I do colonoscopies in people with positive Cologuards, more than 3/4 of them turn out to be negative. They're totally fine. It was a false positive all along, although that's good news for the patient. And the last limitation is that for all these stool tests, you shouldn't use them if you've had a personal history of polyps or cancer, or you have a family history of polyps or cancer, or if you have conditions like ulcerative colitis or Crohn's disease. So there are some limitations there. Next slide. Just a quick comparison, and this, again, doesn't necessarily mean that one is absolutely better than another, but I put this slide up just to illustrate that things like stool-based tests have a harder time picking up polyps. So colonoscopy does a good job at finding both small and large polyps and letting you take them out, and also does a very good job at finding cancer. FIT tests find very few polyps. They do an okay job finding cancer, not great, but if you do it annually, it adds up. Cologuard does a pretty good job at finding cancer. Really, you find less than half the polyps that you find with a colonoscopy. And since polyps turn into cancer, that's a big limitation for Cologuard. Next slide. There are a few other screening tests. Again, just a quick mention for them because you may hear about them. So flexible sigmoidoscopy is basically half a colonoscopy. It's easier in terms of prep. It's less expensive, but it only sees half the colon. And again, I mention it because it, along with that fecal occult blood test, was one of the modalities that was originally tested and originally showed an effect on colorectal cancer incidence and mortality. A CT colonography, which is also called a virtual colonoscopy, is a special type of CAT scan that looks at the colon. You may remember when President Obama went and had his colon screening, he actually opted to have a virtual colonoscopy as his test. So it's like a CAT scan, but just a bit special. You have to take a prep, just like you're having a colonoscopy. They have to put some air in. There's a little bit of radiation. It's a little bit less sensitive for polyps and colon cancer than a colonoscopy, but it is an option for some people who only want to do a colonoscopy if truly needed, or where a colonoscopy may be technically more challenging. And then the last thing that I'll mention, because you might see this too if you start Googling around, is what's called a capsule colonoscopy. So it's basically a little pill, kind of a neat gizmo, and you swallow it, and it works its way through, and it has a little camera on it that's attached to a little radio transmitter and a battery, and it goes through your insides, through your colon in this case, and it beams out the pictures to a little box you wear, and you get some pictures of the colon from the inside. So it's got some promise. It's improving. It's not yet approved as a standalone test, though. Next slide. So why get screened? I've told you all of this before, but just to summarize, you get screened because colorectal cancer is common. You get screened because colorectal cancer is preventable. You get screened because colorectal cancer is very treatable if found early. And most importantly, we've shown that screening has been shown to save lives. Next slide. There are lots of organizations that can give you different recommendations. Basically, first-line tests or colonoscopy or FIT. Cologuard, second line, maybe first line. The other tests are sort of a backup if needed. But the bottom line, next slide, is that if you're 45 or older, just get yourself screened. And any screening test is better than no test. And if you don't know if you should get screened, ask. Next slide. And that's it for National Colorectal Cancer Awareness Month from me. So I'll turn it over to.
We'll jump in and just do a couple questions. Thank you so much for that presentation, Dr. Bogardus. So why 45? Why not 40 or a different age?
That's such a great question. So with any screening program, you're trying to balance the burdens of the screening program and the benefits of it. And at age 40 and age 30, colorectal cancer, even though I told you that it's increasing in incidence, is still quite uncommon. So I think in most people's minds, it's not common enough to warrant trying to reach out to everybody and screen everybody in that group. You'd have to do too many tests to find too few cancers. But by the time you get to 45, those numbers are beginning to shift. And it seems to make sense when you model this out. There are enough people now at 45 who have colorectal cancer or who have polyps, where if you try to implement a screening program for everybody, the number of tests to the number of problems you find starts to make sense in terms of cost and everything else. I hope that made sense.
Excellent. Yeah, thank you. And another question that's common is the rise in incidence in young adults. Can you tell us a little bit more about that, why we think that might be happening?
I think it's a great question. I think the honest answer is that we don't fully know yet. But it's a noticeable, it's a consistent observation recently. And, it may be due to changes in diet and weight and diabetes and other lifestyle factors like that, activity. Those are some potential things. There may be other factors as yet unmeasured in terms of what we're exposed to. I think many people suspect that some of those lifestyle issues may be playing a role. I think we're still a little bit unsure.
Great. Thank you so much for those answers and for the presentation, Dr. Bogardus. Next, we'll move to Dr. Kevin Du from Radiation Oncology.
Terrific. Thank you so much, Dr. Cecchini. So as I was just trying to figure out how to unmute. I'll start off by introducing myself. My name is Kevin Du. I'm associate professor at the Yale School of Medicine, Department of Therapeutic Radiology, and medical director at the Trumbull Radiation Oncology Center. And as many of the folks here on this panel are, I specialize in treating gastrointestinal cancers, including colorectal cancers. And it really is terrific to present our various thoughts to the attendees here. And thank you for attending this session. It's really nice to be here with all of you. I'll say that one thing which this panel demonstrates, and which I think is a very important part of how I think about radiation oncology, is really this idea of a multidisciplinary effort. And when a patient comes and meets one of us, they're really talking to the Yale GI experts and the group, and we take care of patients together. And really, it's a real conversation and multidisciplinary effort to figure out what the best plan is to take the best care of our patients. And so, I like this because this slide, because it shows that, for example, many patients, I think, intuitively understand surgery. Many folks intuitively understand chemotherapy, medical oncology. I think radiation oncology is a bit of a question for many people, and it's because we use radiation in a fairly measured way, and but it is an essential part of the multidisciplinary care of gastrointestinal cancer patients, and we're routinely discussing between all our specialties, how to best incorporate each of our different treatments. So it's the question of what is radiation oncology. And I think it's important to think about that radiation, of course, is a natural phenomena. And we are constantly exposed to radiation in our environment, with cosmic rays, radiation here, ambient radiation here on Earth. And it's been something that we've really evolved with in our biology. Our evolution has really adapted to over the development of our species. But radiation, if you'll indulge me, was really first discovered as a phenomena and characterized in the late 1800s. And here's a picture of many historical figures, for example, Roentgen and Marie Curie, Pierre Curie, who characterized and much of the initial radiation phenomena in the 1800s in France. The very shortly after figuring out that radiation was a phenomena, they actually realized that if you handled it too much, that you would cause tissue damage, and very quickly translated this within only a few months of discovering the phenomena of radiation into treating cancer patients. And this is in a time before chemotherapy. It was a time when surgeries were really big surgeries, because everyone who presented with cancer presented with advanced cancer and not early stage cancer, as Dr. Bogardus was telling you, which is so important for the cure of cancer, to catch cancer early. That radiation really became one of the dominant treatments for radiation. And this was really in the early stages, really at the turn of the previous century, before really understanding what radiation was doing. In subsequent years, in the subsequent 100 years, radiation has really become very sophisticated. And if you can think about all the advances in nuclear physics, the understanding of the atom, of DNA, in our molecular biology advances in the past 50, 60 years, all the advances in technology, in computer technology and in engineering, all these things are incorporated together to really customize radiation therapy for our patients, and really, I think, in a very meaningful way, provide a personalized treatment for patients using the combination of our understanding of physics, biology, and the utilization of advanced technologies. So when I say personalized patient care, again, I'll go back to this idea of a multidisciplinary effort to figure out the best treatment approaches for our patients. And of the overall category of colorectal cancers, I'd like to focus in on specifically rectal cancer, and using rectal cancer as a example of how we approach patients with a multidisciplinary approach in order to optimize patient outcomes. So The rectum is really distinguished here, and I apologize, I don't know if you can see my cursor, but the colon is most of the bowel, but then just at the very bottom of the colon, right before the anus, is the part of the colon called the rectum, and the rectum is really distinguished by two things. It's a very highly functional area. And really the muscles that control continence form this kind of muscular bowl almost in your pelvis. And these muscles are intimately associated with the rectum. And these muscles are the muscles that control your bowel movements, control continence, and are very important for bowel function. And then the second thing to think about is that unlike the rest of the bowel and the rest of the colon, the bony pelvis, where the rectum lays right at the bottom of this bony pelvis, of this bony bowl, I should say, at the bottom of the pelvis, really is kind of a very enclosed space, unlike the rest of the bowel, which is very readily accessible by surgery, this bony pelvis limits access and limits exposure by our surgeons. And so space is limited, more limited than the rest of the colon. And cancers of the rectum are also closer to the pelvic muscles, which means that if you try to do surgery, one, there's less space to get around rectal cancers, and two, that there's a risk as you're trying to remove the tumor, as the surgeon is trying to remove the tumor, that these muscles may get damaged, leading to long-term, symptoms and difficulty with bowel movements. So we use radiation to really help our surgical colleagues to try to, where we aim radiation at rectal tumors to try to decrease the size of these cancers before surgery. And it's been shown to not only improve surgical outcomes, decreasing the risk of leaving perhaps some microscopic rectal cancer behind after surgery, but it can also reduce the risk of cancer recurrence following surgery, and really trying to shrink things up to get things to move, to try to get the cancers to move away from the muscles, to avoid really decreases in bowel function and potentially in some patients the risk of having a colostomy bag. And in about half of patients, radiation and chemotherapy together can really actually cause a complete remission of cancer, where you may potentially avoid surgery if in carefully selected patients. And so here's an example of a radiation plan where, again, we're really trying to be very measured and very careful in how we're aiming radiation. And what we have here is pictures of a person's pelvis. And you can see, if you haven't seen this before, this is a CT scan, and these are basically slices looking at a patient with a CAT scan. Here you can see the bones, and those are the whiter parts of these images here. The top of the leg bones, the femoral heads, and the front of the patient, front of this patient is here. The back of the patient's here, and the sides over here. And in the middle here, you can see the rectum. And the colors are really an example of how we can shape and aim the radiation field to really be very conformal aiming at the rectum and the lymph nodes around the rectum, while sparing normal tissues like the bowel, which is in front, the bladder, and also the femoral heads on the sides. Very similarly, this is a view from the side of the patient, showing again aiming at the tumor here in red, and then the lymph nodes here in the lighter blue color. And so this is really something where for every patient we come up with a customized radiation plan. This is a very precise delivery, and really the overall goal of radiation therapy is to try to aim properly at the tumor, treat the tumor as best we can, but reduce the risk of side effects by reducing radiation exposure to the patient's normal tissues. Switching tracks, we can also use radiation treatment as a non-invasive ablative type of treatment, something called SBRT, which stands for stereotactic body radiation therapy. And this is a way that we can, for example, treat patients where maybe the tumor has spread to the liver, and we can aim radiation at individual lesions in the liver to kill off the cancer cells there, or potentially even spots in the lung where we can aim radiation and kill off spots of cancer that may have spread to the lung. And again, this is a really good example of a multidisciplinary approach where SBRT is one of many ways that we may address these types of lesions that have spread to other parts of the body. And it's important to talk about it in a team approach together with all the physician specialists to make sure that patients are being treated with the treatment that best serves them. So again, to summarize then, radiation therapy is really a customized treatment approach. And we operate, very much in the context of a team effort, taking care of patients all together between surgery, chemotherapy, and radiation, taking into account all the details of the patient and the patient's story. So thank you. If there's any questions.
Thank you, Dr. Du. One question. So for somebody that's coming in for radiation, can you outline the time they're with you for the day? Like, how long does that take?
Sure. So, we have many different types of radiation courses, but radiation is typically given as an outpatient treatment. There are treatment courses of radiation that are as short as one treatment to as long as 6 weeks of daily radiation treatment. So, from 1 to 30 treatments, for as we're talking about these types of treatments. Most typically for rectal cancer, we're talking about something like 30 treatments. There's also the potential for shorter treatments, more something like maybe even as short as 5 treatments for rectal cancer. Each radiation treatment is generally about maybe 10 to 15 minutes long. So even though it can potentially be a lot of visits coming back and forth to my department for the radiation treatments, each treatment is very short. And many patients can come back and forth and continue to do the things that they need to do, continue to work even during the radiation treatment.
Great, thanks for that outline. And a question that's come through in the chat, when would you choose not to use radiation on a patient? And so maybe in the context of rectal cancer.
Yeah, so I'll go back to this idea of radiation. The real purpose of radiation for rectal cancer in particular is really to try to improve the patient outcomes in terms of function, quality of life, and recurrence of the cancer. And so, this is something where, when we all get together, as we do on a very regular basis, and discuss our patients all together, we kind of nitpick a lot over the details of the patient case. Where is the cancer? How big is the cancer? What's the impact on the patients, in terms of how the patient's feeling, or their, again, their bowel function is very important. And so there are cases where, potentially the risks, of the side effects of radiation, the exposure of the radiation, would outweigh the benefits, versus other patients where it's very clear that, if that maybe the radiation would help greatly with the patient's quality of life, and bowel function. And so, these are things that are very much an individualized discussion. And again, among physicians, where we all have a great amount of experience in terms of our treatments and figuring out the impact on patients' lives. But certainly, there are, the short answer, I would suppose, is, there's definitely cases where the benefit of radiation is admittedly small, and the patient may very well spare themselves from radiation treatment.
And how do you choose between SBRT, shorter courses of radiation, and longer courses of radiation?
Sure. So the main thing that we think about with short courses versus long courses of radiation it's really about thinking about the potential for patient side effects. And what happens is, overall, we want to give an effective dose of radiation that will kill off cancer cells. And what happens is, you think about going back into the history of radiation. What happened was, initially, when they used radiation, they gave, and this is in the 1800s, they gave radiation all as one big shot. They just held, they had some radium, and you just hold it there until the tumor regresses. But, probably about 50 years ago, they realized that if you split up radiation to small doses and gave radiation slowly over time, and that's where the 30 treatments comes from, that radiation actually becomes more tolerable, and it becomes safer in terms of long-term side effects, and also adjusting, the radiation treatments for short-term side effects if you need to. You can always stop treatment if the patient is having side effects. So many times we think about longer courses of treatment historically as being safer and better tolerated, and you can change the course if you need to. But more recently, as we're getting better with delivering radiation, it's becoming more well tolerated. We're actually going back to maybe treating larger shots of radiation over a shorter period of time. And that's where the short courses of radiation come in. And, the short courses are more convenient by far. And they, in many cases these days with modern radiation, they're probably just as safe. But, it does depend on the location. So, with big shots of radiation, once you give that big shot, you can't take it back. And there can be the potential for long-term side effects. So you have to be very safe with these big shots of radiation, and that depends a lot on the location of the tumor and where you're aiming.
Great. Thank you so much, Dr. Du. Next, I'd like to introduce Dr. Anne Mongiu, one of our colorectal surgeons, who will present next.
All right. Well, hi, my name is Anne Mongiu, and I am an assistant professor of colon and rectal surgery at Yale New Haven. And tonight I'm going to talk a little bit about, as a surgeon, how we think about surgical therapies for both colon and rectal cancer. I don't have any disclosures. And so I always like to start with, where do I fit in, just like everyone else has before me this evening. And so when I think about cancer treatment as a whole, I was always taught that you start by naming it. And that's the pathology that comes from that biopsy that Dr. Bogardus did. And the pathologist will take it and they'll tell us what type of cancer it is and what it looks like and what we need to think about from that point. And the next we stage cancer, and people usually for colon and rectal cancer that will involve some form of imaging, and that can be a CT scan or an MRI scan, or very rarely a PET scan. But these are all pictures that we take of you basically from your neck all the way down through your pelvis, and they let us see not only probably where the colon tumor is, but also if there's any evidence that it could have spread elsewhere, to another organ or to some lymph nodes. And when we have that information, then we come together as this team to treat it. And with the nice pictures that Dr. Du just gave us, it is a customized fit for every patient. There is chemotherapy for rectal cancer. There's also radiation therapy. And then there's me that comes in with the surgical side of things. And sort of like we just discussed with radiation, timing of surgery can vary based on what type of colon cancer or rectal cancer you have, what stage it is when you present initially, and sort of what other treatments that when we discuss you as a group. In our case, most of the folks here meet on Monday afternoons at around 4:30 in the afternoon. We actually go over a lot of our colon and rectal cancer cases as a group on a Zoom talk, not so dissimilar from this one. And we go through the naming and the staging of the cancer and making up plans that we all agree on together, for your care. So when you're seeing one of us, you're really actually seeing all of us. And it's not just me, it's a whole division of colon surgeons, a whole bunch of radiation oncologists and oncologists. And so that's sort of what we bring together. But for my side of things, I think about the surgical side. So I just wanted to answer some real basic questions about colon cancer surgery. So the first one is, what is a colectomy? And a colectomy is just a very generic term for when we go and take out a part of the colon. So the picture that you're looking at on the stream is the big guy that you saw before going all the way around on the outside. It goes up, around, down, and out. This is your colon, or your large intestine. And when we look at these pictures, it's always backwards, because it's like you're looking at me. So here's my right hand. It's always on the left side of the screen. When we take out the colon for cancer, we want to think about and be mindful of a couple very important things. So it's not just the part of the colon that contains a cancer, but it's the blood vessels, which are these guys here. It's the big blood vessel, the aorta, and then all these little blood vessels, they supply each part of the colon. And so when we take out the colon, we want to get the colon, the blood vessels that could have brought cancer there, the blood vessels that could drain cancer away. And then we also want to take out what we call the lymph nodes. The lymph nodes are these tiny little organs. They're like peas or jelly beans, and they live around the blood vessels that feed the colon, and they're parts of our immune system. They contain white blood cells, and they contain different immune cells from our body that can sense cancer and fight cancer, but they're also the route of lymphatic drainage in the body, and cancer cells can get into these lymph nodes, and that's often the first place they go before they move on to another solid organ in your body, such as your liver or your lungs. So when I think about doing a colectomy, it's not just taking out a piece of colon or even seeing a tumor and cutting the tumor out. I'm thinking about a plan that's going to give you the best chance of taking out the colon cleanly on both sides with the blood vessels and the lymph nodes that the pathologist will need, so we can actually finish the staging of the cancer. Now, colectomies come in a lot of different flavors. In this picture, the dark green areas would be the part of the colon that we take out, and we have names of them. Some of them are historic names. So a low anterior and a high anterior resection are the surgeries that we would do for a rectal cancer. And so we don't usually call it a rectal colectomy or proctectomy, but we usually call the surgery a low or high anterior resection. And this has to do with the anatomy of the structures we're operating on when we're going deep into the pelvis. Others have more convenient names like a sigmoid colectomy for the sigmoid colon or a left or right hemicolectomy. Again, most of these we center around where we see a tumor. Now, you might notice that some of these down here on the bottom, you're like, wow, that's an awful lot of colon that's highlighted there. Why so much there? Well, there are other folks who can get colon cancers, and these are some of the hereditary diseases. So sometimes folks who might have something like inflammatory bowel disease or ulcerative colitis or Crohn's disease, not only can they develop an inflammation that goes across their colon, but they can also develop cancers. And a lot of times when we have to do surgeries in patients who have those type of inflammatory bowel disease, we do take out more of the colon because we know that the colon that remains behind has an increased risk of developing a cancer. But this is just a little bit of the idea of what we take out. Now, a lot of it, and I'll talk a little bit more in the surgical technique section a little bit further down, is how are we doing it? And the most important part is that when we do this, when we take out a part of the colon, part of what we need to do is divide the colon safely on both sides of where the tumor is. And usually we do that with something that's a very fancy stapler. It's a lot nicer than your average office stapler. It both lays down a track of staples and it divides it so we can actually divide the colon, keeping it sealed off on both sides so that we don't spill anything in the process. And then after that, we take the ends and we put them back together. And usually we do that with another different kind of stapler. And we create a plumbing conduit that's just as good as new, but with a part missing. And that brings me to the question that Dr. Du touched on briefly, and that is, well, what is a stoma or an ostomy or a bag? And am I going to need one with my colon cancer surgery? And so the words stoma and ostomy, they derive from the Greek and Latin respectively that mean mouth. And what an actual stoma or ostomy is where we pull a part of the intestine after it's divided through the abdominal wall, and then stool will empty out through that part of the intestine and it won't go downstream from there. Usually it empties into what people call a bag, or we call an ostomy appliance. And that's a little plastic pouch that has a sticker on it that adheres to your abdominal wall and collects it so that it doesn't make a mess and it keeps it all contained in one area. But the good news is today, most folks don't need to have a stoma with their colon cancer surgery. Some of the notable exceptions there are emergency surgery. And oftentimes, if someone comes in with a perforation from a cancer and we have to do an emergency operation, or they have a blockage of the cancer that's spread in multiple places where the most important thing that the patient needs is to get a stoma or to get the blockage taken care of and get straight to chemotherapy, then those are times when we do make a stoma. And some can be temporary and permanent, as I'll talk about in a minute. And then there are also cases that I'll talk about when they do have to be permanent. So how do we decide what is a temporary or a permanent stoma? And so temporary stomas, I call them like a detour. Those are stomas that we make to protect a connection that we might have made further downstream. When I talked about those type of colon surgery, we talk about rectal cancer surgery in particular, most patients who are coming to see me for rectal cancer have gotten some treatment with radiation therapy up front, and sometimes even with a number of months of chemotherapy. We know that radiation and chemotherapy help shrink those tumors. In fact, they shrink them away from the very valuable sphincter muscle. And by doing so, that allows us to actually take the tumor out cleanly with good clean margins and put you back together and save the sphincter muscle so that ultimately you will go to the bathroom out your bottom again. But when we put those two ends back together, that's the second fancy stapling that we do. We know that after there's been radiation and chemotherapy and you're operating low in someone's pelvis, the risk of that plumbing job having a small amount of leakage actually is quite high, somewhere in the order of 15 to 20%. We generally consider that to be a little bit too high of a leakage rate. So what we do is we put the ends back together on the inside, and that's the hardest part of the operation. And we bring a small piece of the little intestine or the small intestine up through the skin. And that basically serves like a detour, and it keeps the stool away from the pelvis so that area can heal without any stool running through it. And we know from a lot of studies that have been done that that temporary detour actually allows the area to heal safely in most patients. And 4 to 6 weeks later, we're able to close that temporary stoma and it goes away and it's like they never had it. Another time when we have to make a temporary stoma, sometimes folks will present with advanced stage colon cancer. And that's cancer that's spread to another organ, such as the liver or the lung. And in that case, when the cancer is spread outside and away from the colon and it's blocking the colon off, the best thing I can offer is to create a detour right away. That detour takes us very little time in the operating room, and the recovery is really quick. And what that means is you can get on to chemotherapy safely and quickly and get what is the most needed treatment for the tumor that you have. Now, as we have said, there are some muscles very low down in your pelvis. Those are called your anal sphincter muscles. And those are the muscles that squeeze when you don't want to go to the bathroom. If the cancer is actually invading into those muscles, as some very low rectal cancers do, and we can't treat it well enough with radiation to make it go all the way, or it's going through both muscles and it doesn't recede, then at that point in time, we do have to talk about making a permanent stoma or a colostomy, because there isn't actually a way to safely provide good cancer care and leave those muscles behind. And if we have to take the muscles out, the continence would really be reduced to zero. Fortunately, even in my practice, I see very few people where this is the case. We really don't have very many rectal cancers nowadays that are caught that are eating into the muscles. And so for the most part, with the surgical techniques and some of the advanced imaging we have in the OR today, we're able to do surgery to remove even the lowest of rectal tumors and still put you back together again, even if it does require 4 to 6 weeks with a temporary stoma. And so that brings me here to how do we do colon and rectal surgery today? This is from Ether Day, back about a little over 150 years ago. And all surgery originally was done, we call open. And that's a big incision. And for people who've seen someone who had belly surgery a while ago, it's a long up and down incision, vertical in the middle of your abdomen. That gives us good exposure and ability to see and do a surgery safely. We don't tend to do that so much anymore today. Really, keyhole surgery or minimally invasive surgery has actually been in the works for more than 100 years, but safely in abdominal surgery for general surgeons since the late 1980s, early 1990s. So keyhole surgery, or we call it laparoscopic or minimally invasive surgery, is where instead of making that big vertical incision down the middle of your belly, we make a couple of 1 centimeter or even ½ centimeter incisions, and we stick very small little clear plastic tubes or straws through them, and we blow your belly up with carbon dioxide gas. And this gives us room to work with delicate cameras and long, skinny instruments. This is what laparoscopic surgery tends to look like. And you can see here, the one gentleman who is operating is holding both a camera and an instrument in his hand, and he's looking up at a monitor where he can see in this case, the liver. He can see the organ that he's operating on, and he's able to do so and take out the whole colon and do the same surgery that they would have done with a big incision through a really tiny set of minimally invasive incisions. And people tend to recover really quickly from this surgery because it's a lot easier to recover when the holes are about the size of your thumb. We've gotten more advanced in the last 10 to 15 years, and you may have seen or heard about what we call robotic surgery. And Yale really does embrace robotic surgery. It's probably my preference for surgical technique, and it's what I spend most of my time doing elective colon and rectal surgery on. The robot has 2 forms, and really what it is just a fancier version of laparoscopic surgery. There's the actual robot that you see over here on the left side of the picture. And this robot, it doesn't move on its own. You bring it over to the operating room table. And after we've actually put those same ports in the patient's belly, we then clip them onto the robot, and then we use the robotic instruments. Now, the robotic instruments are really exceedingly fancy, and they surpass anything that we have available with laparoscopic surgery, in that they actually have joints and wrists on them, and they're able to move in multiple directions, actually with more dexterity than even the human hand. And a single surgeon can now control a camera and 3 separate instruments, which normally if you were operating by yourself, you've got 2 hands to operate with, and now you've actually have 4. And so it's a really neat technology. The camera itself has 2 separate lenses in it, and so it actually provides 3D viewing. And so the surgeon, after the ports are put in, actually sits down at this console right here. It's about 5 foot away from the patient in the operating room. Everyone stays sterile. And you look into this 3D viewer, and what you have is a 3D view of the inside of the abdomen. And this little hand panel down here has foot pedals you can't see, and it has some hydraulic hand graspers. And these allow you to control with millimeter precision the instruments that do all of the cutting, the dividing, and the stapling that we talked about for doing those colectomies. It's a really powerful device, and for operating deep in the pelvis, especially for rectal cancer surgery, and especially for those patients that have tumors that are very low in the pelvis to a point where they're almost at the level of the anal sphincter complex, the stability and the 3D imaging and the 10x magnification of the robotic platform actually allow you to see all the way down to that level of your pelvic floor from inside, and allow us to make very precise dissection that allows us to go all the way down to those muscles. Furthermore, and this is just on the really fun side of things, what you see here is the same piece of colon on the left and the right side. We also have the ability to use lasers and advanced imaging even while we're doing surgery in real time now. There's a dye that's called indocyanine green. It's a fluorescent dye, and the anesthesia attending or the anesthesia doctor that's in the room while we do the surgery, when we get ready to divide the colon, taking the part that where the cancer is and then separating it from the healthy colon, we want to know after we've taken all those blood vessels that the part of the bowel that's left behind actually has really good blood supply. And the dye actually, which is activated by a laser through the robot, glows bright green. And you can see right here, there's a real clear line. You see the little bump on the side of the colon here that you can see right here. And you can see this clear line. It tells us that this side of the colon is really good and healthy and has great blood supply. And this side is where we have taken away the blood supplies. It's one of those instruments for doing that. And you can see we should cut here because we want to save the colon that's got good blood supply. When you look at it in the white light, the normal color that would appear to your eye, and this is the view that we have from inside the robotic console, you can only maybe see a subtle change in color here, but it's really stark here. So our robotic technology even helps us in trying to find those exact points where to make our cuts and our stapling. And that actually helps us reduce the risk of leakage when we do robotic surgery. And so that's a little bit about our techniques of surgery today. I wanted to end just by saying a little bit about what we call ERAS, or enhanced recovery after surgery. So just like we work as a team with oncology and radiation oncology for cancer treatment, we work as a team with anesthesia in pre and post-operative nursing at Yale to make your recovery from surgery even faster than it was before. We go through extensive instructions and pre-op diets, and we don't make you stay without eating for that long before surgery anymore, because we know that there are ways that we can speed the return of your bowel function after surgery. We have nurses in the hospital that are really great getting people up right away after bowel surgery and walking them, because we know that helps. We use certain medications that have been shown to help the return of bowel function come more quickly. And we also use what we call multimodality pain therapy, which means we rely on medications other than just opiates. We know that by doing so and by doing some blocks in the OR, we can reduce pain and the need for opiates, and opiates slow bowel function. So we try to do everything that we can, both before and after, with our teams with anesthesia and nursing, also to get you through surgery faster and with less complications. And so really, from my point of view, that's a little bit about the surgical side of colon cancer treatment. Thank you very much for coming tonight to listen. And I'm really happy to take any questions on colon cancer or rectal cancer surgery.
Thank you, Dr. Mongiu. One question is, can you talk a little bit about the functional changes that maybe happen after, for example, a rectal surgery, and other team members you might work with to manage any symptoms?
That's a great question. So as we talked about before, the rectum is that very last part of your colon. It's the reservoir. I like to think about the rest of the colon absorbs a lot of the water and sugar and salt out of it, but the rectum in particular, it serves as a reservoir. And you can think of it as being a very sensitive organ that's got pressure sensors on it, just like your car might have pressure sensors for the tire and the tire pressure. Your rectum has pressure sensors all the way around it for when it's full with stool and when it's empty. That combination of radiation, chemotherapy, and surgery, and then taking a whole different part of your colon for rectal cancer patients, usually your sigmoid colon, and putting it back there in the place of your rectum causes some changes in bowel function. And that's because we've disturbed both the nerves and we've used a new piece of colon. This disturbance in bowel function can be constipation, it can be incontinence, it can be unpredictability of bowel movements. As I had mentioned at the very beginning, we call rectal cancer surgery a low anterior resection. That's just the name of it. And this syndrome of sort of abnormal bowel function afterwards is called low anterior resection syndrome. We know that it affects about 40 to 50% of patients who have rectal cancer surgery, and it's noticed once we close that temporary stoma. It usually takes about a year for patients to get back to their normal baseline after surgery. And we are working actually on studies here at Yale to see if we can identify patients who might be at higher risk of this, and also other studies to take a look at whether or not treating aggressively with pelvic floor physical therapy, even before you undergo surgery, can minimize this. But even after surgery, we know that there's a lot of medical therapies that can help with this, and also pelvic floor physical therapy or irrigation of the anal canal are some treatments that are used nowadays to help people get back to their normal lives as soon as possible after the rectal cancer surgery and get back to having a better quality of life. Our group at Yale works very closely with our pelvic floor physical therapists, and quick and early referrals can usually help patients to get back to their normal function a little bit sooner. We also work with our nutritionists here to help patients adapt their diet in the beginning and start figuring out what works well for them and what doesn't. Ultimately, by about a year after surgery, most people can go back to eating whatever it is they like. But those first 6 months after surgery, sometimes we need a little help to keep the stools a little bit firmer. When they're a little bit firmer, people have better control and you can relearn how to sense things once again.
And a couple other questions coming in through the chat. Can you comment a little bit on the difference between ileostomy versus colostomy, and then also on the rate of cancer, the percentage of recurrence and screening after surgery?
All right. So great question. So a colostomy is a stoma or ostomy that's made from the colon. And that's where we bring up a part of the colon or large intestine through the skin. An ileostomy is actually from the small intestine. The terminal ileum or ileum is the very last part of the small bowel, and that's the part of the small bowel that inserts into your colon. And so that part tends to have more liquid stool that's high in bile, and the output tends to be more of a green liquid. A colostomy tends to have normal brown stool that's much more similar in appearance and consistency to the stool that would otherwise normally come out your bottom. So that's the sort of the difference between them. The next question was on recurrence after cancer surgery and our screening guidelines. So depending on, so recurrence and surveillance, I think probably in some sense, Dr. Kortmansky may touch a little bit on surveillance, but surveillance after colon cancer surgery usually involves what I call 3 modalities. It's going to involve imaging, which might be CT scans or MRIs. It's going to involve a little bit of blood work, and it's going to involve a colonoscopy and screening colonoscopy. So the NCCN, or National Cancer Center Network guidelines, usually suggest that a colonoscopy be performed 1 year after the date of surgery. In the event that the original surgery was with an obstructing cancer, then we usually recommend that you get that screening, that where the whole colon had been screened beforehand, before we did the surgery. We do often recommend that you try to go on the earlier side to get that 1 year colonoscopy. But otherwise, if your cancer was found on a screening colonoscopy and we do surgery a few weeks later, we recommend surgery a year from the time of your surgery. Recurrence is rare, but not impossible to happen in the area of the colon where the original tumor was. When we talk about taking out the colon with clean margins, that usually means we're taking about 5 centimeters at a minimum on either side of that tumor. And the reason we do that is we want to be far away from the marked tumor so that we have normal tissue on both sides and really little chance of spillage of any cancer cells that could have spread there. So occasionally I will have patients referred to our practice that will have a recurrence in or around the area where we've put them back together, but overall that's quite rare. Okay, that's a couple of the questions. I know there was another one.
Well, I think in the interest of time, we'll move on to Dr. Kortmansky's presentation. Thank you again, Dr. Mongiu, for that excellent presentation. And next we'll have Dr. Jeremy Kortmansky from Medical Oncology to present. You're muted, Jeremy.
Now can you hear me?
Yes, now we can.
All right. Thank you. So I'm going to switch gears a little bit, actually, and I was going to talk tonight about the progress we have made in terms of personalized treatment for metastatic colorectal cancer. So this is patients that cancer has already spread to other parts of their body. So I'm going to talk a little bit about how we stage a patient, left versus right-sided colon cancer, and then the various molecular targets that we have therapies for. And so this is really kind of how, as medical oncologists, we think about individuals who come to us. It's clear that everybody is a little bit different, and those differences need to be considered in the treatments. So there will be some molecular biology, but I will try to keep it simple, I promise. The routine staging starts with the colonoscopy, where the diagnosis is often made. We look at blood work, your blood counts, and your liver function tests, and then a marker in the blood called the CEA, which is a protein that can be given off by the cancer cells that we can follow over time. We do a CAT scan of the chest, abdomen, and pelvis, and then sometimes we'll do a PET scan as well. And so the images on the right, the picture up top is a CAT scan. The picture on bottom is a PET scan. You can see that they are pretty similar. A CAT scan gives us an anatomic picture, whereas a PET scan gives us a metabolic picture. Where are there active cells that we need to think about? And so when we look at a CAT scan and we see that cancer has spread, we do make a difference or make a distinction about whether it's a single site of disease, what we call oligometastatic disease. And in these pictures, the one on the left, you could see a single lesion in the liver, and the one on the right, a single lesion in the lung. And that's important because when we only see one, we do think about the possibility of resection along with the rest of the disease, taking it out surgically, and thinking about cure. When the cancer is more disseminated, and here you see much more involvement in the liver or the lungs, this is a more difficult problem to operate on. And we are thinking about controlling the disease with our treatments, helping people live longer and feel better. One of the distinctions that we also have to make is where the cancer started. So the colon is not all the same. We have divided it into the right side of the colon and the left side of the colon. And that there's differences because when we were embryos early on in our mom's bellies, where the right side of the colon developed from and where the left side of the colon developed from were different. And so the pathways are different. And when we think about colon cancer, it actually behaves and looks differently. How it might appear on a colonoscopy, what types of adenomas or polyps you might see, which mutations you might see, where the cancer may be likely to spread. Cancers that start on the right are more likely to spread into the abdomen. Those on the left may spread to the liver or lung. Differences in the ages of onset of cancer, differences in whether it's a male or a female who gets it, how advanced it is when it's found. Cancers on the right tend to be earlier stage, whereas cancers on the left tend to be later stage, and even how it's going to respond to the treatments that we have. One of the other tests that we do is, and has become increasingly more important, is called tumor profiling. So looking at the cancer, not just in an anatomic way and not just under the microscope, but really understanding it at the level of the proteins and the DNA on the inside. One way is to look at immunohistochemistry, which are staining on the surface of the cell. Every cell has a signature, and we can use that signature to tell us a little bit about what's driving that cancer. Or we can do DNA sequencing. So actually taking a sample of the tumor and then testing for different mutations in the genes. And then the other way is to use circulating tumor DNA. So instead of sampling the tumor directly, we can take a sample of blood. And in that blood, we can see DNA that might have spilled out of the cancer cells and is now circulating. This pathway called EGFR is really the most common pathway that we think about in terms of the molecular behavior of cancer. So colon cancer in general has EGFR overexpressed. That means there's a lot of it on the surface of the cell. And when it is activated, it creates a whole cascade of reactions that lead to cancer cell growth and survival and travel. And so in these pathways is where we think about the different treatments that we might have. The first is a group of tumors that have EGFR increased, but no other abnormalities beyond that. And so when that EGFR is activated, it leads to growth. And we have drugs that if we block that EGFR pathway, so cetuximab and panitumumab, we can combine that with our chemotherapy to have a better effect on the cancer. Now, what's interesting, getting back to this left and right, is that drugs like cetuximab and panitumumab work really well in combination with chemotherapy when the cancer starts on the left, and work not at all really in cancers that start on the right. And why is that? So the makeup of left versus right cancers is very different. So in this cartoon, all the different colored circles represent different proteins that might be abnormal in a cancer. And you can tell that on the right, it's a very different color than on the left, because the proteins that are abnormal are different. And so those differences are going to help determine what a cancer cell may be sensitive to or may be resistant to in terms of the treatment. The most common abnormality that we see is actually a mutation in KRAS. We see this in about 30 to 50% of colorectal cancers. KRAS is the next step after EGFR. And so when that is mutated, it's always on. It's always driving that growth below it. And so whatever happens above no longer matters. So even if you target this with an EGFR drug, it's not going to help because the KRAS is not going to be turned off. And so having this mutation predicts resistance to anti-EGFR therapy. For a long time, we thought that having a mutation was a limitation in terms of our treatments, but we're also seeing that particular mutations can be targets for treatment. And so specific mutations like KRAS G12C or KRAS G12D are new targets that we are looking at in clinical trials to help those patients that have these mutations. Another mutation is a BRAF mutation, which BRAF comes right after KRAS. And we see that in 10% of patients with colorectal cancer. And interestingly, while KRAS mutations are more common in cancers of the left, BRAF mutations are more common in cancers of the right. But BRAF is also a targetable mutation. And there was a very important clinical trial that came out that looked at drugs that targeted BRAF, so encorafenib and binimetinib, in combination with a drug that targets EGFR versus what is typically our standard of care, irinotecan and cetuximab. And in this study, we saw that targeting BRAF, which is the lines on top, the purple on the left and the blue on the right, improved our control of the cancer and improved how long patients lived. So giving a targeted therapy rather than a chemotherapy, patients did better. And this combination is now a standard of care for patients with BRAF mutated tumors. We tend to use 2 drugs instead of 3 because the results were pretty similar, but 2 drugs is a lot less toxic. Also on the surface is a family member of that EGFR, which is called HER2. And HER2 also drives a lot of pathways that lead to cell growth and proliferation and survival. HER2 has a lot more notoriety in the breast cancer population, where a lot of the drugs were initially developed. But we are now learning that it is present in multiple cancer types, including colon cancer. We think about it being amplified, meaning that there's a lot of receptors on the surface of the cell, and that's what's driving the activity beneath it. And when we target HER2, this is what we call in our studies a waterfall plot. So all of these lines on the right that are going down is cancer responding to the therapies. And so when you give a combination therapy targeting HER2, you see very dramatic responses. And in fact, in some, this one all the way on the right is somebody that their cancer went away completely on their imaging. And just last month, back in January, a new drug was approved called tucatinib, which is a pill that targets HER2, that when given in combination with trastuzumab, which is an IV drug, it controlled the cancer in 70% of patients. And in patients that have had a response, that response lasted for over a year. So a very powerful way to treat cancers that is different from chemotherapy. I want to switch gears a little bit to DNA mismatch repair. So what is DNA mismatch repair? So DNA is our codes for our entire makeup. And every time a cell divides, it has to copy its DNA. And sometimes when it copies its DNA, it makes a mistake. And there are mismatch repair enzymes that come in, identify the mistake, and then allow a second protein to come in and fix the mistake. And so this is what it's supposed to look like. But in patients that are mismatch repair deficient, what we call microsatellite instability, those enzymes are missing. And sometimes they're missing because of hereditary syndromes like Lynch syndrome. And sometimes it happens because they're not really missing, but they're turned off by another mutation. But either way, what it looks like is very similar. And what that is thousands of mutations that develop within a cell that ultimately lead to cancer. And you can see here where there's on the bottom, where there's mismatch repair deficiency, there's over 1,500 different mutations, whereas in a sporadic cancer without mismatch repair deficiency, there's very few. And while that sounds really alarming, all of those mutations actually attract the immune system. And so the immune cells in patients that have mismatch repair deficiency or microsatellite instability, if you look at that cancer under the microscope, you can see lots of immune cells that have entered into the area. And if there are a lot of immune cells that have entered into the area, then there is a potential benefit from immunotherapy. So medications that activate the immune system to fight cancer. And in this waterfall plot, the blue represents mismatch repair deficient colorectal cancer that was exposed to immunotherapy. And you can see how often it responds to the treatments, to the immunotherapy, as compared to the red, where it does not have mismatch repair. So immunotherapy works really well if you have this mismatch repair deficiency, and doesn't work all that well if you don't. In a study that compared immunotherapy to our standard chemotherapy for patients with this microsatellite instability, the immunotherapy was better in terms of duration of control and response and how long patients lived. And this has become our new standard of care for first-line treatment. So if you look at where we are in terms of guided therapy in 2023, 30% of patients have the KRAS, BRAF wild-type tumor on the left side. Another 3% have that KRAS G12C, and 10% have KRAS G12D, and 10% have BRAF mutations, and 3% have HER2 amplification, and another 4% have microsatellite instability, which means that over 60% have a potential biomarker with therapies that we are looking at now, and with other therapies that are still in development and new targets that are coming down the pike. And so progress for metastatic colon cancer is definitely being made. There's still more to do. And what all of us can do to help make that progress is stay active and get screened to avoid getting colon cancer. If you do, seek multidisciplinary care. Have a team of doctors that are all looking after you together. And if there is an opportunity, participate in clinical trials, because all of these advances that we have made are from patient volunteers helping to find new therapies and better therapies and helping patients live a little bit longer. So thank you all for your time.
Thank you, Dr. Kortmansky, for that excellent presentation. So you just ended there talking about clinical trials. Can you tell us when patients should be asking their doctors about clinical trials?
So all the time. I think that clinical trials are often confused as a last resort for someone's cancer. But the reality is that every treatment that we have has been studied in a clinical trial at some point. And that includes clinical trials, figuring out the best screening to do, whether it's colonoscopy or Cologuard, what treatment to do after you've had a colon surgery. Do you get 2 chemotherapy drugs, 1 chemotherapy drug? And in all settings of advanced disease, whether you're first diagnosed or whether the cancer has grown on the treatment that you've had. And then also, if there are no more standard options left, then that is a time also to think about clinical trials. So there is always an appropriate setting, and there's always a need. Until we have cured everybody, there is always a need to try to move the field forward.
Excellent, thank you. And you spoke very nicely about how we are, I think, thinking about this type of cancer is with many different subgroups of the cancer. What should patients know about the molecular makeup about their tumor?
I think we have an obligation to share that information. I think these are things that we check on everybody that we are thinking about starting treatment on. Microsatellite instability, those mismatch repair enzymes, is a a standard test that we do on every cancer specimen that we see. And so the more detailed molecular testing, we are doing it earlier and earlier. But it's important to share that information so that patients understand why we are choosing the treatments that we are. When it comes to things like microsatellite instability, which are potentially a sign of a hereditary syndrome like Lynch syndrome, it's important for patients to know that, get genetic counseling if appropriate. So we're not only looking out for them, but their families as well.
Great, great. One just final question that came right through the chat before we end. What's the vision, or at least your vision, that oral therapies will play in the future? Do you think they'll take a more prominent role than they currently have?
So I think a lot of the drugs that I talked about today are oral therapies. There are oral therapies for the BRAF mutation and the KRAS mutations. And so, but like any other therapy, they also have side effects. So just because they're oral, it doesn't mean that they're necessarily easy to take. We see things like diarrhea or fatigue or rash. And so I think our future is one that is going to balance and continue to focus on ways not just to give the right drugs, but to manage the side effects that they cause.
Great. Well, thank you so much. And I think we're at time. I'd like to thank all of our panelists, Dr. Bogardus, Dr. Du, Dr. Mongiu, and Dr. Kortmansky. And I'd like to thank all the people that attended in the audience today and for your attention this evening. Thank you. Have a great night.
Thank you.